Welcome. In this session, we are going to discuss about anterior uveitis arising from non-infectious causes. And non-infectious anterior uveitis is the most common form of uveitis encountered in a general ophthalmology clinic, accounting for more than 90% of all uveitis cases. And when we see a patient with anterior uveitis, as we are going to describe, it is important to rule out primary involvement of sclera and/or cornea, as in sclerouveitis and keratouveitis. Acute non-granulomatous anterior uveitis is typically unilateral, with recurrences occurring unilaterally in either eye. That means that it may involve the right eye or the left eye in different episodes, but it does not involve both the eyes simultaneously, and the patient complains of sudden onset of pain, redness and photophobia with or without mild blurring of vision. On examination, we find ciliary congestion, fine keratic precipitates, cells and flared in anterior chamber with fibrin and/or hypopyon in severe cases. So here we find ciliary congestion, hypopyon and fibrin reaction visible in the pupillary area. It is important to note that in the first few days after onset of an attack, anterior chamber cells may not be observable in the slit lamp, and it may only be detected after a few days. Seclusio or occlusio pupillae can occur with or without iris bombae. In seclusio pupillae, the entire 360 degrees of the pupillary margin is adherent to the anterior lens surface. In occlusio pupillae, the entire pupillary aperture is blocked, and because of seclusio and occlusio pupillae, the pressure of the aqueous in the posterior chamber increases, pushing the iris forward, resulting in iris bombae. And this iris bombae, if chronic, may result in peripheral anterior synechiae. The IOP may be low because of cyclitis or may be raised because of blockage of the trabecular meshwork by inflammatory cells, by trabeculitis or by peripheral anterior synechiae. We may find cells in the anterior vitreous, but cells in the anterior vitreous are much less than the cells in the anterior chamber, and so the cells in the anterior vitreous are supposed to have been spilled off from the anterior chamber in anterior uveitis. Macular edema may occur in anterior uveitis. Here we find peripheral anterior synechiae occurring from seclusio pupillae, and in this portion the iris appears to bulge forward. Coming to workup for anterior uveitis, acute unilateral non-granulomatous uveitis does not require routine diagnostic tests for uveitis, as has been described in a previous session. So it must be acute, it must be unilateral, non-granulomatous, not to require routine diagnostic tests for uveitis. Sacroiliac radiology and HLA B-27 testing is indicated. So in the radiograph, we find that the adjacent bone surfaces of the sacroiliac joint are rough, the joint space is reduced, and there is sclerosis of the adjacent bones. Laser flare interferometry is an equipment which helps us to objectively analyze aqueous flare, but it is available only in academic settings. However, in chronic intractable anterior uveitis, routine uveitis tests must be done. In addition to routine uveitis tests, PCR for viruses such as cytomegalovirus, herpes simplex virus, varicella zoster virus and rubella virus, as well as tuberculosis is indicated as appropriate, and cytology or histopathological examination for masquerade syndromes such as leukemia and retinoblastoma can also be ordered as required. Treatment of anterior uveitis is basically two-pronged: anti-inflammatory and mydriatic cycloplegics. Most acute anterior uveitis presentations can be adequately controlled with topical steroid only, and prednisolone acetate 1% is the drug of choice. The acetate salt helps in penetration of the cornea, and the topical steroid is initiated at 1 to 2 hourly dosage during waking hours, and it is very important to tell the patient and attendant to vigorously shake the bottle before application in order to increase the efficacy of the drug. Severe anterior uveitis not responding promptly to topical steroids may need periocular or systemic steroids, and frequently recurrent anterior uveitis or chronic anterior uveitis, which requires either more than 2 drops of topical steroids or more than 7.5 mg of systemic steroids for more than 3 months, should be started on antimetabolites or TNF inhibitors. Mydriatic cycloplegics are required to relieve pain and photophobia from ciliary spasm, to break already existing posterior synechia, to prevent development of new posterior synechia, and to allow visualization of the posterior segment. And it is important to remember that short-acting mydriatic cycloplegics are preferred because they help to keep the iris mobile. Coming to HLA B-27 associated seronegative spondyloarthropathies, typically they are associated with acute non-granulomatous anterior uveitis, and 40 to 50% of acute non-granulomatous anterior uveitis have HLA B-27. Now 8% of general population also have HLA B-27, and so HLA B-27 by itself is not a diagnostic marker for spondyloarthropathies. And if anterior uveitis is not associated with either HLA B-27 or any other related systemic symptoms and signs, it is called idiopathic anterior uveitis. And this idiopathic anterior uveitis not associated with either HLA B-27 or with any other systemic symptoms or signs is usually the most common form of anterior uveitis encountered in the clinic. And among HLA B-27 spondyloarthropathies, we have ankylosing spondylitis, reactive arthritis, inflammatory bowel disease, and psoriatic arthritis. And some cases of these HLA B-27 spondyloarthropathies are not distinguishable among these entities. The common features of HLA B-27 spondyloarthropathies are an absence of rheumatoid factor, presence of HLA B-27, spondylitis, that means pain and morning stiffness along the spine, sacroiliitis, that means pain and morning stiffness in the hip joint, and anterior uveitis. 90% of ankylosing spondylitis patients are HLA B-27 positive, and among the HLA B-27 spondyloarthropathies, ankylosing spondylitis is most closely associated with HLA B-27 positivity. Ankylosing spondylitis is characterized by morning stiffness of the lower back and hip joints, which improves with activity. Family history may be present. Sacroiliac imaging studies are indicated, as we have discussed in the previous slide. An early diagnosis and treatment institution can minimize or delay onset of deformities. It is important to detect ankylosing spondylitis in a patient with acute anterior uveitis because these patients may develop aortic valvular insufficiency or pulmonary apical fibrosis. In reactive arthritis syndrome, also called Ritter syndrome, 50 to 75% show HLA B-27 positivity, and the clinical features are a classic diagnostic triad of urethritis, polyarthritis, and conjunctivitis. The polyarthritis is asymmetric and oligoarticular, that means it involves only a few joints, and the typical joints are knees, ankle, wrist, and feet. And the conjunctivitis is typically papillary with a mucopurulent discharge. Other typical features of reactive arthritis are scaly erythematous lesion of palms and soles called keratoderma brenoregica, and of the glands called cercinate balanitis. The non-granulomatous anterior uveitis in reactive arthritis syndrome may become chronic and bilateral. They may also have punctate epithelial keratitis and subepithelial keratitis, and as a part of HLA B-27 spondyloarthropathy, they can also have sacroiliitis. Reactive arthritis syndrome usually follows diarrhea or dysentery and predominantly affects males. 20% of inflammatory bowel disease patients develop sacroiliitis, and 60% of them are HLA B-27 positive and may have acute anterior uveitis. There are also IBD patients which are actually HLA B-27 negative and thus do not fall in HLA B-27 associated spondyloarthropathy, but it should be mentioned here they have rheumatoid-like arthropathy instead of sacroiliitis, and they may develop sclerouveitis and intermediate uveitis. In psoriatic arthritis, there is a classic triad of psoriasis, which are scaly erythematous lesions of the skin, distal interphalangeal joint inflammation, resulting in an appearance called sausage digits. So here we find distal interphalangeal joint inflammation with swelling of that region, resulting in the appearance called sausage digit. And associated with that, there are typical nail changes or ungual involvement. 20% of psoriatic arthritis patients have sacroiliitis, and 25% of psoriatic arthritis patients have anterior uveitis, which is usually insidious and bilateral and can become chronic. Anterior uveitis may occur with psoriasis without arthritis but in older individuals, and this presentation is more chronic as well as bilateral and can have posterior segment involvement. So after HLA B-27 associated spondyloarthropathies, we are going to discuss the other anterior uveitis entities. Tubulointerstitial nephritis and uveitis or TINU occurs predominantly in females in second and third decades, and clinical features include general symptoms like fever, anorexia, malaise and arthralgia, abnormal serum creatinine level and abnormal urine analysis findings. The anterior uveitis is bilateral and non-granulomatous, and the anterior uveitis becomes more severe in recurrent disease. In Glaucomatocyclitic crisis or Posner-Schlossman syndrome, there are recurrent unilateral attacks lasting hours to days. Unlike the typical acute anterior non-granulomatous uveitis, these recurrent unilateral attacks involve the same eye, and during these attacks, the patient complains of discomfort, blurring of vision and halos. There may be mild non-granulomatous anterior uveitis with few keratic precipitates and low-grade cells and flare, but there is a marked elevation of intraocular pressure. So this is the primary feature of the disease associated with a mild anterior uveitis, and the pressure may be 40 to 60 mm of mercury, and it is said to result from blockage of trabecular meshwork by mononuclear cells. Associated corneal edema may be present. In Glaucomatocyclitic crisis, both anterior uveitis and raised intraocular pressure need to be treated. It has been reported that untreated episodes of Posner-Schlossman syndrome can have occurrence of non-arthritic ischemic optic neuropathy with loss of vision. Glaucomatocyclitic crisis has been associated with CMV infection, and in CMV infection we usually get corneal endotheliitis with linear and coin-shaped capes, and this occurs predominantly in males. An anterior chamber tap for PCR can be done to detect CMV, and anti-CMV therapy is indicated. Fuchs uveitis syndrome, previously known as Fuchs heterochromic cyclitis, is typically unilateral. So this is a characteristic feature of the disease, and quite recently it has been associated with intraocular infection with rubella. Fuchs uveitis syndrome is usually asymptomatic and thus incidentally detected or have mild blurring of vision with mild discomfort. Typical feature of Fuchs uveitis syndrome is diffuse iris stromal atrophy resulting in heterochromia, and this diffuse iris stromal atrophy results in moth-eaten iris. So this appearance is called moth-eaten iris, and when we compare it with the other eye, the difference becomes even more apparent. Now in brown-eyed patients, the involved eye becomes lighter in color, and in blue-eyed patient, the involved eye becomes darker in color. In Fuchs uveitis syndrome, we find small white capes distributed all over the endothelium, and they are typically white in color and stellate in shape. There may be low-grade cells in the anterior chamber and in the anterior vitreous, and bridging vessels across the angle has been described. And a characteristic feature of Fuchs uveitis syndrome is that posterior synechia and macular edema do not occur. Complications of Fuchs uveitis syndrome include cataract, glaucoma, hyphema and vitreous opacification. The hyphema is often post-surgical and occurs from bridging vessels in the angle, and is called Amsler's sign. In Fuchs uveitis syndrome, topical steroids are ineffective and are actually not required. Cataract surgery is well tolerated and glaucoma may require surgery. In lens and IOL associated uveitis, we have several entities: phacoantigenic or phacoanaphylactic uveitis, phacolytic uveitis or phacolytic glaucoma, endophthalmitis, toxic anterior segment syndrome or TASS, and uveitis glaucoma hyphema syndrome. In phacoantigenic uveitis, also known as phacoanaphylactic uveitis, there is immune reaction to lens proteins exposed to the aqueous humor after disruption of the lens capsule following trauma or surgery, and histologically granulomatous reactions is found surrounding the exposed lens material. So this is a patient showing phacoantigenic uveitis following vitrectomy, during which there was disruption of the posterior capsule. In phacoantigenic uveitis, the anterior segment inflammation can be non-granulomatous or granulomatous. Keratic precipitates, often mutton fat, and posterior synechiae occur, and retained lens matter following disruption of the capsule is often found in anterior chamber and vitreous cavity, with cells and haze in the anterior chamber. IOP is often raised, and if severe, phacoantigenic uveitis may resemble post-operative endophthalmitis. Treatment is lens matter removal and anti-inflammatory therapy. In phacolytic uveitis or glaucoma, there is leakage of lens proteins through intact capsule in an eye with an hypermature cataract. So in phacoantigenic uveitis, lens protein is exposed following disruption of the lens capsule, but in phacolytic uveitis or phacolytic glaucoma, there is leakage of lens proteins through an intact capsule. Macrophages phagocytose the leaked lens protein and go on to block the trabecular meshwork, and signs include markedly raised intraocular pressure, refractile bodies in the anterior chamber, which may be detected with the slit lamp, which are actually lens protein laden macrophages. However, keratic precipitates and posterior synechiae are typically absent. So this is a severe case of phacolytic uveitis or phacolytic glaucoma, and we see the leaked lens protein getting deposited in the anterior chamber angle as well as present in the anterior chamber. Treatment is urgent cataract surgery with anti-inflammatory and hypotensive therapy. Pre-existing uveitis can recur following cataract surgery, and it is recommended that the cataract surgery should be done only after the eye is quiet, preferably without any therapy, for a minimum of 3 months after an episode of anterior uveitis. And this is a very important recommendation to follow in routine practice. Infectious endophthalmitis following surgery also belongs in the differential diagnosis of post-surgical inflammation and is a dreaded condition, and it will be discussed in a subsequent session. Toxic anterior segment syndrome or TASS is a non-infectious condition and occurs due to reaction to drugs or chemical injected into the anterior chamber during a surgical procedure. Toxic anterior segment syndrome usually presents within 24 hours after cataract surgery, unlike infectious endophthalmitis, which typically presents after 2 to 3 days of surgery. Patients with TASS have mild pain and characteristically have corneal edema, which can be marked, but no vitreous inflammation. So this is a patient with TASS presenting on the first post-operative day following cataract surgery, and we can see the typical corneal edema. Uveitis glaucoma hyphema syndrome, also called Ellingson syndrome, occurs following cataract surgery and IOL implantation, and it occurs due to irritation of the anterior uveal tissues by an intraocular lens. At present, UGH syndrome occurs most commonly due to a single-piece hydrophobic acrylic IOL implanted in the sulcus, whether inadvertently or not. And this is also a very important principle of cataract surgery, that a single-piece hydrophobic acrylic IOL should never be implanted in the sulcus if there is a posterior capsular disruption, and we should always opt for a 3-piece IOL for sulcus implantation. And it is also important to make sure that a single-piece hydrophobic acrylic IOL has gone inside the capsular bag in its entirety. UGH syndrome can also be due to an undersized ACIOL because an undersized anterior chamber IOL has a propensity to move inside the eye. And there are also few reports of UGH syndrome occurring after implantation of a 3-piece IOL in the ciliary sulcus. UGH syndrome is characterized by localized transillumination defects of the iris at the site of iris chafing. So this shows a patient with uveitis glaucoma hyphema syndrome, and here we see a iris transillumination defect in the shape of the IOL haptic touching the iris. Pigment dispersion may be there due to rubbing of the iris. Intraocular pressure is raised because of the inflammation and pigments blocking the trabecular meshwork, and occasionally there may be hyphema. An anterior segment OCT or an ultrasound biomicroscopy can detect malposition of intraocular lens causing a UGH syndrome, and the treatment of UGH syndrome is IOL explantation or exchange. A large number of drugs have been known to cause drug-induced uveitis, and among them we have rifabutin, cidofovir, moxifloxacin, immune checkpoint inhibitors used for cancer therapy, topical prostaglandin analogs and brimonidine, intravitreal anti-VEGF, urokinase used to dissolve blood accumulating in the eye, and intravitreal antibiotics. Now coming to another very important topic, juvenile idiopathic arthritis associated uveitis. The uveitis associated with JIA is usually bilateral chronic anterior uveitis. 80 to 90% of JIA associated uveitis occur with oligoarticular JIA, in which there is involvement of 4 or less joints in the first 6 months of the disease, and it is usually ANA positive and more common in girls less than 5 years of age. So bilateral chronic anterior uveitis, oligoarticular JIA and ANA positivity are characteristic of juvenile idiopathic arthritis. The remaining 10 to 15% of JIA associated uveitis occur with polyarticular disease, in which there is involvement of more than 4 joints in the first 6 months of the disease, and in systemic onset JIA or still disease, anterior uveitis is rare. There is another form of JIA called enthesitis related arthritis, in which the tendon insertions in the bone are affected, and this occurs in older boys, and it is associated with HLA B-27, ANA negativity, acute unilateral anterior uveitis, and development of spondyloarthropathy later in life. So uveitis associated with enthesitis related arthritis is more like the typical acute non-granulomatous anterior uveitis we face routinely in the clinic, and is different from the typical bilateral chronic anterior uveitis associated with oligoarticular JIA. 8% of all JIA develop uveitis, and the average age of onset of uveitis is 6 years, and the onset usually occurs within 5 to 7 years of onset of arthritis, and there is no correlation of severity of the uveitis with severity or timing of the arthritis, and the risk of uveitis in JIA increases with oligoarticular disease, female sex, ANA positivity, RF negativity, and early onset of arthritis. It is common for JIA associated uveitis to be diagnosed incidentally because most patients are asymptomatic with a white eye. However, some patients may complain of photophobia, blooding, or mild pain. We find fine non-granulomatous keratic precipitates, anterior chamber cells and flared posterior synechiae and cells in the anterior vitreous. Being a chronic uveitis, complications of JIA include band keratopathy, glaucoma, chronic hypotony-orthitis, cataract, and macular edema. The poor prognostic predictors of JIA-associated uveitis include male sex, uveitis occurring before the onset of arthritis, present at the onset of arthritis, or onset of uveitis very shortly after the onset of arthritis, or vision loss and complications are present at presentation of uveitis. ANA testing and pediatric rheumatology consultation in suspected cases are recommended, and arthritis can be minimal at onset of JIA or the associated uveitis. And patients with JIA but without active uveitis should be monitored every 3 months, particularly if the patient is ANA positive or has oligoarticular JIA. Active uveitis should be treated, and topical high-potency steroids at a very frequent dose are to be initiated as early as possible, and it is very important to instruct the parents to shake the bottle vigorously before application of the drug. Systemic IMT or immunomodulatory therapy is preferred over systemic corticosteroids because long-term administration of systemic corticosteroids have serious adverse effects including growth retardation. Systemic immunomodulatory therapy is indicated if topical steroids are required 3 or more times daily for more than 3 months, and in children methotrexate has been found to be generally well tolerated. And as IMT takes effect, steroids, whether topical or systemic, can be withdrawn. And it has been seen that chances of relapse after cessation of therapy with methotrexate is reduced if the uveitis is inactive for 2 years of methotrexate therapy. Biologics are also an option, and adalimumab is the preferred biologic for treatment of uveitis, and when response to adalimumab is suboptimal, another biologic can be tried. It is very important to also prescribe mydriatics, particularly short-acting mydriatics, to keep the iris mobile and to prevent posterior synechiae from occurring. Removal of cataract is important to prevent amblyopia, but it should be done only after 3 months of quiescence of the disease. Pre- and post-operative immunomodulatory therapy is preferred when cataract surgery is performed, and options of cataract surgery include acrylic IOLs or lensectomy vitrectomy. Some experts prefer lensectomy vitrectomy and keeping the child aphakic because there is some evidence of increased incidence of hypotony if posterior capsule and anterior vitreous is retained. Following cataract surgery, close follow-up and long-term monitoring is essential. And following cataract surgery, we should have a low threshold for IOL explantation if the IOL is not tolerated. As regards management of glaucoma, response to ocular hypotensives is usually suboptimal, and trabeculectomy with antifibrotics or shunts may be required. Cystoid macular edema is treated with periocular steroids or vitrectomy, and hypotony is a very serious complication indicating a poor prognosis, and it usually does not respond to any therapy. Now there is a recommendation from American Academy of Pediatrics as regards frequency of ophthalmological screening for uveitis in JIA, and it is mostly based on ANA. High-risk patients need to be examined every 3 months, and they include both polyarticular and polyarticular patients with ANA positivity. Medium-risk patients should be screened every 6 months, and they include both polyarticular and polyarticular patients who are ANA negative. All high-risk patients become medium-risk patients between 4 and 7 years of onset of arthritis. Low-risk patients need to be screened every 12 months, and they include patients with systemic onset JIA or Still's disease, and all patients become low-risk patients 7 years after the onset of arthritis. This will be ANA negative. Kawasaki's disease can also have mild anterior uveitis, and it occurs usually before 5 years of age with fever, cervical lymphadenopathy, rash and mucous membrane changes. Ocular involvement usually presents as conjunctival injection, but mild anterior uveitis may also be present. And Kawasaki disease needs to be treated early because of significant complication if not treated, which includes coronary artery aneurysm, which may lead to sudden death. So this is a very important list of uveitis with hypopyon, and they include microbial keratitis and endophthalmitis, HLA B-27 associated acute anterior uveitis, Behçet's disease, which is actually a pan-uveitis, and rifabutin induced anterior uveitis. Differential diagnosis of anterior chamber cells or flare, that is, conditions which are not primarily inflammatory but may show cells and flare in the anterior chamber, and these include ocular ischemic syndrome, neovascular glaucoma, pigment dispersion syndrome, masquerades such as retinoblastoma and leukemia, and trauma. Schwartz-Matsuo syndrome is not a true inflammation, and it follows retinal detachment with a break anterior to the vitreous base. Dislodged photoreceptor outer segments leak through the retinal break, migrate to the anterior chamber, and float in the anterior chamber as pigmented cells, and they raise the intraocular pressure by clogging the trabecular meshwork. Schwartz-Matsuo syndrome, being non-inflammatory, does not respond to topical steroids. Intraocular pressure can be lowered by aqueous suppressants, but repair of the retinal detachment is the definitive therapy. Thank you for listening.